Okay, so Economics 101. The classic textbook for economics undergraduate student is written by this guy, Greg Mankiw. So this is just funny. Like many years ago, he had that on his blog, that there's the 6th edition now, just in time for Valentine's Day. So, yeah. If your boyfriend gives you that, it's probably not a keeper. Okay, anyway, in this book, he introduces 10 principles of economics in basically chapter 1. And you can see I've only put 6 here, yeah, because 7, 8, 9, and 10 are more for macroeconomics. And that's not really that important to health economists. So we don't, I should understand them, but I don't fully understand them. So, and they don't really matter for what you want to do. So let's focus on 1 to 6. And specifically, because we don't have the whole day, or not a whole term, we're going to do just 1, 2, and 3. So the first one is people face trade-offs. So if you want to do one thing that you would want to do, usually you have to give up another thing that you would also like to do. So here I've got an example. You might have 1 hour, and you could spend that hour studying, or you can spend that hour working in your part-time job in a coffee shop. But you can't do both, yeah? So if you work, so you have some income, so you can have nice days out, then you can't study, so you might not get the grade that you wanted to get a good job later on, so that you don't have to work in a coffee shop for the rest of your life, yeah? Or at the level of maybe government or local government, we have to make decisions about, we could invest money into education, or we could support local businesses, yeah? But we can't do both, because a pound spent on this can't be spent anywhere else. So we constantly face these trade-offs. And so to make decisions about trade-offs, we think about the costs and the benefits of the 2 different options, or the 3 options, or how many options you are considering, and you can only make one choice. And the cost of something is what you give up to get it. That is the cost. So the cost is not the money that you have to give somebody for something, it's what you have to give up. So if I go to university for 3 years, the biggest cost is that I can't work in a full-time job over these 3 years. So obviously there are the tuition fees, but in our system, they are not really. They're more like graduate tax, yeah? So the biggest cost is the opportunity cost, that you could have worked in a full-time job, maybe at the minimum wage, yeah? So that's why you go to university, so at some point you don't have to work at the minimum wage, but it's sort of 24K times 3. That's the biggest cost, the opportunity cost. So why is Mick Jagger here? Because he fully understood the idea of opportunity costs. Yeah? So he was actually a student at the London School of Economics, and he never finished his degree. He's a dropout because the opportunity cost of finishing his degree, the cost of finishing his degree, were just too high. And the cost was the millions of pounds he could have earned if he'd focused on his music career, which obviously he did because he was a student at the LSE, yeah? So he dropped out and instead pursued his music career. Okay, so something less funny. So when this is an example from a health economics textbook, so if it's too healthy, so health-based, sorry about that, but there's a really good example. So they calculated if you offer IVF on the NHS, like 3 courses, that at some point used to be the standard recommendation, that you get 3 courses of IVF. One course is, at that point, was about £3,300. Yeah. So if you do 3 of those, what could you have done with the money if you hadn't spent it on the 3 courses of IVF? 1 heart bypass operation, yeah, 9 cataract removals, or 300 MMR vaccinations. So these are things that we're giving up when we're saying we're doing this. This is what we can't do. And you can go beyond the healthcare sector. So you could look at where else could government have spent that money? So it could have paid for 1/3 of a police constable for a year, or 3/4 of a teaching assistant, or 5,000 school dinners. So I'm not sure how exactly these numbers work out these days, because it's from a book from 2012, but you get the idea, yeah? So that's the idea of opportunity costs. If we do this, we can't do that. And so the really technical definition of opportunity cost is the next best thing, the next best use of these resources, yeah? So it's not like, oh, but if you don't go to university, you would just be sitting on the couch for a year and watching daytime telly, yeah? So that's not the next best use of your time. Yeah, the next best use of your time would probably be getting a job. Yeah, so you shouldn't compare that against creating nothing. Okay, so that's opportunity cost. And the third principle, rational people think at the margin. So that means you don't think about things as a whole, you think about one step at a time. So instead of, should we stop doing education? That's not the decision that we make. It's like, should we maybe build another further education college, or should we make young people go to school for another year, which we've done, yeah, instead of 16, I think it's 17 or 18 now, yeah. So we're thinking around the edges of what we're already doing, hence marginal analysis. And so this is going back to the IVF example. So don't really bother so much about the numbers, but it's just to show you where the 3 cycles potentially comes from marginal analysis. So this paper, they tried to work out what's the cumulative live birth rate. So first cycle, in that study, like 30% of women had a live birth, yeah? So that's sort of the standard success rate they tell you, like 30% chance. I think if you're under a certain age, like not if you're 50 or something like that. And then what about the second cycle, third cycle? So if you keep going, what's the cumulative birth rate? And it's not easy to estimate, hence they have 4 different ways of estimating that, because there are some women who drop out after the first one because they don't want to go through this again. But if they had done another one, maybe they would have gotten pregnant, yeah? So they have lots of different assumptions, like the dropouts are age adjusted or prognostic adjusted. So like if you go with the most optimistic one, the optimal estimate, yeah, which is like really optimistic, but you can still see the diminishing marginal returns at work. So like the first one, 30%, do a second cycle, you increase it from 30 to 47%. So the jump is 17 percentage points, yeah? So the first one was 30, second one is 17 percentage points. Then the next one, the jump is 12 percentage points. The next one is 8 percentage points. So there's this diminishing marginal return, basically. So maybe at this point, yeah, that's not worth it. Like if you haven't gotten pregnant by the third cycle, the chances just go up a little bit each time. And maybe that small increase in the chance of having a baby is not worth another £3,300. Yeah. So that's basically decision making that we do in everyday life when we think about what we spend our money on. I will come to that in a moment, but here's a more technical example, less fun. So this is from a textbook again. It's an exercise for students, yeah. Consider this table of costs and benefits that you would get from a government policy to clean the water in the local area. So there are different levels of abatement you can achieve, like nothing doesn't cost anything and doesn't generate any benefits, yeah. Reducing the water pollution by 10% costs maybe 10K, yeah. And if you could express the benefits in monetary terms, it would generate benefits of 80K and so on. So how would you decide what's the optimal level of abatement? What should you go for? Let me talk you through it. Okay. So one thing you could do is you could just calculate the difference between the total benefits and the total costs. So I've done that for you, so you don't have to get your calculators out, and I'm not going to test your mental math. So which one would you go for?
No, it's 50%.
50%, yeah, because that's where you maximize the net benefits, basically. And some people might, like if you're from the Green Party, you might say, no, it has to be 100%, yeah. But maybe we can already dispel that myth. No, that would be just generating negative benefits. So that's definitely not okay, yeah. But, oh, look here, like 90%, it's nearly clear, yeah. And we still have a net benefit of 35, so you're not at least making really stupid decisions at this point, yeah. But you can see this much more easily if you do marginal analysis. So marginal means I think about going one step further. So if I go from 0 to 10%, obviously it's the same as this first. So the math starts when you go from 10 to 20%. So to go make it a little bit better, yeah. So we add another 12 70k of costs, and we add another 70k of benefits. So let's keep going. So if we go from 20 to 30, it costs us another 18k, and we get another 50k of benefits. Let's go to 40, another 30, and we get 40 benefits. Here, another 35, 40 benefits. And then here you can see how this becomes the optimum, because you would be spending another 45, and you only get 40 in terms of benefits. So that's clearly not a good buy, yeah? You spend more on the next unit than you get in benefits. So basically you could stop here. So all you need to know is step by step, yeah? You don't have to know all of this, yeah? You basically can stop at the point where the marginal costs exceed the marginal benefits. So that's the thing about thinking at the margin. And you do that in your own life. So for example, today you might be thinking about buying ice cream. And usually, I'm talking about my experience, of course, it might be very different. Like my husband has a very different attitude to ice cream. Like one scoop, yeah, maybe it costs £3, yeah. And if it's really hot and I'm in a good mood, I would be willing to pay maybe £4 for it. So I'm happy to buy that first scoop. Or would you like another scoop? No, that second scoop maybe, but I'm definitely not willing to pay £4 for that, because the benefit that another scoop gives me, maybe the monetary value is £1.50 for me, yeah. A third scoop, maybe it's worth 50p to me. Fourth scoop is probably negative, yeah, because by then I will start feeling sick. But there are others who can, so it's this diminishing marginal return, yeah. And so you would stop at the point where the next scoop, you have to pay more for it than the benefit that it gives you, yeah? If you're paying with your own money, you would never, something that you value at £10, you would never spend £20 on that, yeah? And they know that. That's why they have menus like this, yeah? So like, you can already see the single versus double, yeah? So one is 150, and you only have to add another 90p, because they know that the second one is probably not worth that much to you. And especially with the one scoop, two scoops, three scoops, like 90p, and then it's just 80p that you have to add, yeah? So this is this diminishing marginal return. And that applies to lots of things, not just ice cream, yeah? So pizzas, beers, bingo nights, and things that we spend our money on as a government, basically, yeah? So that's where program budgeting, marginal analysis comes in. So this is basically a method for priority setting. We have been given a budget, yeah, and we could spend it on, at the national government level, housing, education, defense, health, yeah, what should we spend it on? So we could think about that from an economic perspective, where we keep in mind their opportunity costs, and we have to think at the margin, because that's how you make the best decision, if you think at the margin. So this is just one example where they did that in Wales, because Rhiannon Tudor-Edwards, she's based at the University in Wales, and she's very active in that field. Here's another one, from the northeast of England, a little bit more representative, and another one from Wales. Okay, so these are just some examples. So the first step in program budgeting marginal analysis is the program budgeting. So it's not budgeting in the sense of, let's think about the budget for next year. It's about thinking, how much are we currently spending on each of the different programs that we sort of offer, the services that we offer. So you could do it by, so like it needs to be by broad programs. So this, I got that from this lovely book by Gavin Mooney. He is a very interesting health economist. But he's dead now, but he's written lots of interest. He's quite critical. He also got some straightforward economics in there. So you could, by disease group, yeah, so that would be within the NHS, like this is how much we spent on cancer, this on respiratory diseases, this on cardiovascular. By life course stage, that's a more recent thing, that's what they did in this paper in Wales. Or maybe by geographical location, like this part, this part, this part. The key thing is that it's output oriented. So it needs to be relating to our goals and objectives. So this is about, we want to do something good for the early years. Yeah, we want to do something good for young adults. So it's not about, this is how much we spent on nurses. This is how much we spent on this building. This is how much we spent on sticking plasters, whatever you could. So it's about what you're trying to achieve with these, what you spend on. Okay, so that's the first step, and that's already, when you read these papers, apparently really helpful for organizations who are doing that, because they realize where they're spending, yeah, and also how much is tied up, where they don't have any sort of discretion about changing things, where they can't make investment or disinvestment decisions, yeah. And then the second step is the margin analysis. And there are basically three questions that we could answer with a margin analysis. So if there's a fixed amount of resources, is it possible to maybe move 100K from one program to another and increase the benefit overall? Yes, a bit like at the moment, I've got my budget and I'm spending it all on ice cream. And all I can do is like get another scoop, and it's not giving me much more additional benefit. If I could move some of that money over to maybe buy some apples, yeah, maybe overall my benefit would increase, yeah. If more resources are made available, where should we spend them to get the biggest bang for our buck? And if they're to be cut, so if we have a budget cut, where should we cut services and we don't really lose that many benefits? So I've got sort of, again, like an exercise or a practical example to make that a little bit clearer. So imagine, I didn't want to put any names on it, whether it's housing or education. So I just call it Program A and Program B. And usually they consist of lots of sub-programs. So within housing, you probably do lots of different things. And so imagine at the moment they have a total budget of £80,000, because it's very easy to do these things if the money is obviously in real life, it will probably be more billions or something like that. So this is just for the sake of example. And maybe this is how it's being spent at the moment, which doesn't tell us much yet, does it? So we need a little bit more information. So we need to know what are the benefits of all these things that we're currently doing. So like, yeah, we spent £10,000 on this, but what do we achieve with this? And so there are different ways of expressing benefits. Like in cost benefit analysis, we would express it in monetary terms, yeah? That would be quite straightforward, but it's really tough. And within healthcare, it's hardly done because people have some issues about, oh, you can't put a life, like a monetary value on life, even though we basically do, just not as explicitly. So instead, for this example, I've used incremental cost effectiveness ratios, or QALY. So a QALY is like an effectiveness measure in healthcare. It's a quality adjusted life year. So when people started doing economic evaluation, most interventions were literally about extending life, so survival. So basically, the outcome measure was how much do we have to pay to increase survival by 1 year. And then over time, more and more interventions came that don't actually extend life expectancy. They just improve your quality of life. And so then people came up with this clever idea. We could measure it by combining extensions to life with improvements in the quality of life. So that's a quality adjusted life year. So it could be driven entirely by you living another year, or it could be driven by people living much higher quality life years. For example, if something gives you 2 QALYs, it could be, usually you would have lived 10 years at maybe 0.5 quality adjusted, like basically it's between 0 and 1. So a year lived in full health is 1 QALY. A year lived in sort of half health, that's a whole other story. How do we get to these values? Yeah, is 0.5, and a year lived in very low health could be maybe 0.1, something very low. And then it could be also their negative values, because some people would argue some health states are worse than death. You can tell from the debate on assisted suicide, some people really think that, yeah, it's that they have negative QALYs, basically. So what we tend to do in healthcare, we calculate how much does this intervention cost per additional quality adjusted life year. And the standard threshold in NICE is if it costs less than £20,000 per additional quality adjusted life year, it's considered cost effective, for sure. And then maybe if it's 30,000, if you think about it a little bit, and then a lot more if it's like an orphan disease and there's nothing else we can do for this. So it's not that clear actually, but sort of this I've deliberately chosen examples where NICE would say this is considered cost effective. And it's not clear that £20,000 should be the threshold. There are people at the University of York who say it should be actually 15,000 based on what it displaces, what you give up when you say, okay, let's approve this new drug, because then something else has to be stopped. It's back to opportunity cost, yeah. And what does it displace? Hopefully the least effective thing that we are currently doing. And so they try to estimate what is the least cost-effective thing that we're currently doing that would be displaced. And they thought it's actually not that bad. It's just £15,000 per quality, the least effective things, because lots of things that we do in the NHS are quite effective, like providing palliative care nurses or community nursing, these sort of things. They don't cost much money compared to the latest cancer drugs that might not give you that much benefit. So the first thing is you would put together evidence, yeah? So like you look for in the literature, effectiveness evidence, cost effectiveness evidence, and I've made it very easy in this example. So everything has an evidence base. That's often not the case, yeah? But just for the sake of getting the principle across. So let's say this program, it is quite cost effective, only £5,000 per quali. So if you spend 10,000, you generate 2 qualis, yeah? This one, it's a little bit less cost effective, or quite a lot less cost effective. It's £15,000 per quali. And if you spend 15, that means you generate 1 quali. And this one here is sort of in the middle, £10,000 per quali. And they currently spend 15, so 1.5 qualis. So in total, A generates 4.5 qualis with the 40K that they're given. And then here's the same math for B. So they do something that's £10,000 per quali. They spend 20K, so they generate 2 qualis there. Here they have another one, which is not very effective or borderline, like £20,000 per quali. So they spend 10,000, so they generate half a quali with that money. And here's another one, £16,000 per quali. So they spend 10,000, so that's how many qualis they generate. So overall, these guys with 40K, they get 3.125, and these guys get 4.5 qualis out of that. So you can already see maybe we should move some money around, yeah, because maybe they're not using it as effectively as they could. And then you can also see, even within the program, maybe they could make some improvements, because they have this really highly cost-effective one and this not so cost-effective one. Maybe they should shift money from there as well. But maybe you can't, because these are things at the margin. So sometimes, even though you might say, oh, let's put some more money into this one, maybe the next unit of money or whatever you do, like sending nurses out, maybe it doesn't generate that many qualis, because if you're really good at targeting your intervention, you're giving that to the people who really get the most out of it. And then maybe you've covered that population, so you would give it to some part of the population that doesn't actually get that much out of it. So maybe you can't really do it like this. So let's assume maybe you can't. So the next step would be to properly sort things. So you, because at first I showed you, I can't go back. So the first thing is, let's sort things. So this is the most cost-effective, £5,000 per quali. The second one, program C, is actually the second, and this one is probably the least cost-effective. And the same here, so I've sorted them by cost-effectiveness. And then I can start thinking about what if even the least cost-effective one, yeah, maybe these ones, if you get like life course, maybe that's investing in the very early years, yeah, where you really get a lot of return, and maybe that's school years, and maybe that's young adult, yeah, because we know from the literature that you get a higher return the earlier invest, yeah. So maybe you think, okay, maybe add something here, expand that a little bit, yeah. So maybe that's what we could do, and you would still get more bang for your buck than doing this program here. Okay, so we could, for example, take these £10,000 from that program and move it over to this program. So we would add for these £10,000 2/3 of a quali, and we would lose half a quali. So we've gained something, yeah. So in before we had, sorry, we have, like they have gained something. They have fewer qualis, but in total we have more qualis than we had before. And so we didn't need any more money. Yeah, we just move the money in the right place, making adjustments at the margin, and we get some return for that. So that's why you should always think at the margin. Yeah. So here's an example from one of the 3 papers that I showed you, because in real life, obviously, we don't have all these data. There's not this evidence base. So they came up with a weighted benefit score. And then on top of this, they calculated the net cost impact per patient. And it wasn't only just giving, so this one's obviously the best one, but this intervention, for some reason, it has cost savings. Yeah, so you might invest something, but you save something down the line. So it's not just that you move some money around, you literally get savings. Of course, that's highly ranked when you do that. And then you can see how the others are ranked exactly by how much the costs are of doing this versus this versus this. But yeah, so you have to be a little bit creative in real life because you don't have exactly those values. So in this study in Wales, they, it was about sort of what some public health organization spends. And all I did basically looked at, is there any evidence that this is effective? Yeah. And all these things, yeah, look how much they spent on that. They got assessment category red. Based on published evidence, this intervention is unlikely to bring a population health benefit. Yeah. So this is how rough and ready they did that. Yeah. So they didn't do any of these incremental cost effectiveness ratios and qualities, just saying, is there any strong evidence? Not really. Yeah. So maybe if we use that money somewhere else, we could get more bang for our buck. And then they had other things which were amber. Maybe there's something that might be working, but there's also some work needed. And there were a few things, very few things, that got a green rating. This is a sound program with a reasonable evidence base. And surprisingly, when they then did this margin analysis and decided where should we invest, where should we disinvest, where should we just continue what we're doing, these things they wanted to continue. And oh no, I can't go back. And the cooking bus and all this other stuff, they completely scrapped it according to this. I'm not sure whether they did it in practice, but in the paper, when they went through this full process, so it's not just an economist coming in and telling you to do that. Yeah, it's you basically arrange a stakeholder panel, and then you have a first workshop, explain things, then you gather the first program budgeting data, then you have another workshop, then you share the information that you found out. It's all like deliberative process and consultation and these sort of things. I've made it look as if it's just somebody coming from. That's not what it is in real life. So if you want to find out more, these papers are really great examples. That's basically why they're published. Otherwise, it would be a bit boring if every single PBMA exercise got published. Yeah, but they published it because they show you how the process works, all the steps. Okay, so where do the ISA numbers come from?
So, hi everyone. So I'm just going to give you like a quick overview about the very commonly used health economic evaluation designs. I bet most of you have heard about cost-effective analysis. It has been one of the most used term when we are thinking about economic evaluation, and others that are very common is cost utility and cost benefit, which Katharina just mentioned a little bit about it. So in cost-effective analysis, literally we are measuring how much the program costs in monetary terms, how much money we pay for it. And then the outcomes, natural terms, like when I'm spending on that health education program, how many people quit smoking. So the benefit, it's like the impact on the community, and naturally, how many people quit smoking, how many have had reduced blood pressure or normalized blood pressure. And if you are using other standardized surveys that can get you an estimate of the actual change in the quality of life, by how many life gain as an outcome as well. So by having that, you will have a rough estimate about a person stopping smoking cost me that much. And that's a key of information that you think when you are comparing to practically intervention within the same field. Like, would I use a smoking patch or a peer support group? So in that, you have the same outcome, but you wanted to see how much does the patch cost versus the peer support group. But in the cost utility analysis, you practically, the cost is the same, it's within monetary unit, but it's again to a standardized qualities, which we transform that natural unit to how much it did increase, as Katrina said, it's going to increase living well more years in a way. And the comparison is cost per quality. It gives you a little bit of edge because now you can compare smoking versus alcohol use. So now I can compare two programs with different outcomes because the benefit to me that I'm comparing based on it is the numbers of quality gained. So now I can have more comparison beyond that one field that I used to do in the cost effective. And it's usually across different health and social outcomes. When you are doing cost benefit analysis, now we are saying the outcome is how much it gains the society in terms of money. Like if and one of the first example come to me is the long COVID. How many people have stayed behind because if they have long COVID symptoms and they weren't back in the workforce? So that money is lost for the community. So if I treated that, if I prioritize that, I can make that person back into the community as in the workforce and getting more money. So by that, the benefit for the society can be measured in monetary terms. And that intervention that you are using is actually having a monetary return. And again, by that, you can easily see how much it costs the benefit versus the cost that I paid for. And this has opened up a whole new area for us where we can compare increasing numbers of teachers in school and having higher level of education, for example, high quality education versus having an exercise or even healthy meals or supporting, for example, um, nurses and doctors by opening another hospital in the region. So by having both of them on monetary terms, you are going beyond different sectors, comparing education to health in a way.
You must have done
Oh, and, technical problem. All right. So just to not make anything intimidating or hard, it's having an economic evaluation project. It's as any kind of project. You need to define your population. Who would you like to study? And think about the intervention or the programs that you are giving that is implemented for that specific population. Think about a comparison group. How I can compare that. What is the status quo if it's the same population or a different population? What is the outcomes that I'm measuring and how long should I be measuring it for? To be honest, is it a year evaluation, 5 years evaluation? And where is the setting? If it works in Blackpool, would it work in Morecambe Bay? I have no idea. So these are the five, six things that you should think about. And the acronym is Pickett's framework. So it's kind of easy to relate to. So the first one is defining the population, your target population. And the definition has to be specific. And it's a kind of like a specificity, a sensitivity kind of a thing. So you will think about, for example, high risk older adults who live in care homes. They have probability of falling, for example. So this is the population that I want to study and what I can help them with. All right. So older adults who live in the home, they do not fall in my evaluation or my project. So it gives you a sense where I need to be very specific about what is my target population and in terms of who and where and uh, when they are being assessed. And then before we even start, I need to recognize, is it really a problem or not? We have to do a baseline health condition evaluation to see maybe falls is not as much as I think of. So I might not be pushing for designing a program to help them if there's like 5%. that are following. All right. And then once you have defined your population that you wanted to serve or you wanted to make their life better, then you would think about which interventions. And the interventions differ on a very subtle nerve terms. Like seriously, it's something like, can I have an AI lamp, smart lamp, to light the room for those older adults, or having a mat that is soft enough so if they fall, they will not injure themselves. So both of them are technological advances, and the impact for each of them is quite subtle. It's not that huge, like I'm funding a teacher versus a doctor or a nurse. Sometimes you have to decide on this micro level variation. So when you think about the intervention, it's really important to think about two words: visibility and accessibility. So for you, it's just something on the paper. This intervention A costs 10,000, the other one costs 12,000. But you might be spending those 10,000 and no one use it. Literally no one on the ground on the community likes it. And I had a bit of experience about that when there was an intervention that was funded for a medical device where it reminds people to take their medication on time. And for them, it was kind of the residents, it was for older adults in home and living in home to remind them of taking the medication on time. Some people really like it, and others, most of the people, actually were afraid they're being monitored. And you can spend, it makes perfect sense to have a reminder without having like a nurse or a carer coming into your house to remind you. But you have to think about the feasibility and the culture of the community when you are giving an intervention. So it's not easy. It's just other things to think of. And there is cost. So usually when we do our economic project, we think about the direct cost, like how much money I'm spending on that device, and how much money I'm saving by reduced hospitalization or reducing physician and nurses' time, carer time, perhaps even the transportation, the caregiving. But there is indirect cost as well. So if you are giving this intervention or not giving an intervention, the status quo, you might be losing days of work, loss of productivity, as I said, with the long COVID. If you did nothing, you have huge indirect costs you have to think about when you are comparing an intervention to perhaps doing nothing or another type of intervention. This is a very interesting topic, which is the comparison. Do we need a comparison group when we are evaluating an intervention or a project or a policy? Usually when we do, and I've seen it, I think you too have seen it, is that people get very excited about, let's do about that school meals. Let's increase school meals, for example, beyond the primary. I think stops at year 3, and then year 3 to 5 is not there. So how about if expanding to year 5? Okay, fine. But how can I know for a fact if it's working or not? You can only do it if you have a comparison group and other people who didn't implement that intervention to see if it's actually working. And the key term of comparison group is similarity. It has to be almost identical to the group that you have rolled out your intervention or your program in. It has to be within the similar risk condition, and it has to have the same needs as the intervention group. So whatever difference you observe by comparing those two groups, it can easily be identified by your intervention. Oh my goodness, that another year of school meal have really increased the well-being of the children, for example, because I can see it's not about, yeah, I cannot compare primary to high school, for example. They have completely different needs. And how it's assessed, again, usually the comparison, and I think it's all in our nature. You always focus on the group that has the intervention. You observe them. You are talking to them kindly. You interact with them kindly because you are secretly pushing for the intervention to be successful. So it's a human nature, but it's really important that the control group, the comparison group, being similarly closely observed as well, to notice if there is a changes that happen to them that can be biasing or like muddying the results when you are comparing both groups. And again, you have measured your intervention and you are measuring your outcomes with whatever is outcome, either natural unit or quality. But again, how frequent you measure the outcome. And this is very interesting topic because one of my studies that I'm actually working on right now, the results is coming up tomorrow. We compare 3 months before and compare 3 months after the intervention, and the results wasn't that nice. Like it was a very small increase, and but when when we waited and did an analysis 6 months after, oh my goodness, everything was significant. Like seriously, huge improvement from 3 months. So how much, or how often do you need to measure your outcome to see a positive or a negative uh, um, change? And to be honest, the negative change is as important as a positive because it makes you think at the margin, so you are not wasting money in program that is not very useful. You need to allocate it to others. Yeah. And here goes back with the timing. When do you expect to see benefits? Something that require cultural change, something people need to embrace, that intervention, especially with social intervention, it takes time for the community to get used to it and actually utilize it. And with the same time frame that you are measuring the cost, you have to measure the benefits. It's like something to be equal in that in the same time frame. And again, the study, it can be a cross-sectional, like I'm going one time and one shot and measuring what is happening, or you can observe it over time, see that within the 10 or 15 or 20 years moving forward. Um, yeah, and the outcomes might be number of visits and how much it costs to visit. So it's really interesting to see that. But if I can give you anything, leave you with any two terms, please think about the comparison. You have to have a very good comparison to see if your program is working. And think about the feasibility and accessibility of that intervention, because beautiful intervention has been wasted money because the community didn't really like them or use them. Right. Oh, yeah.
Have we got any time left?
It's like 10 to.
Okay.
So 10 minutes left.
Yeah. So this is about the project that I'm involved in, evaluating the national evaluation of the health and social impacts of selective licensing for private rented housing in England. So selective licensing, I'm not sure, does everybody know what this is about? So it's about that not just HMOs need a license, but landlords need a license for normal properties if they are in areas that have been designated as selective licensing area. So the first contribution that we're making with this work is we know where they are. So we had a research associate do lots of FOI requests, yeah, and code it all up, because sometimes they're just street level, sometimes they're big area level, sometimes it's the whole local authority. And so they're not literally coloring in maps, but they code it up, but it's basically coloring in a map. And so we know it looks like not so much. Unfortunately, I didn't copy that across. So we have got one paper already published out of this, where one of the geographers does one of those fancy maps where they increase the size of the area by the size of the population that lives in private rented accommodation. Yeah, and you can see actually we cover quite a bit of the country already. Yeah, this looks a bit underwhelming. Like there are all these parts where nobody lives and nobody privately rents. Yeah. Okay, so that first paper is about what determines where these areas are. So interestingly, there's a lot of overlap with income deprivation when you put these two maps next to each other. What I want to talk about is actually looking at the health and social impact. So we have two types of analyses. One looks at aggregate data, where we just have aggregate level data on things like hospital emergency admissions in that lower layer super output area that is affected. And that's looking a bit weird in places. It's not very exciting because it's very difficult to get that right, because in this area you will have people living in owned, like mortgage owned or owned outright accommodation, but also people living in private rented accommodation. So you mess up your exposure measurement, yeah. So instead, I'm focusing on the individual level data that we have, where I know exactly whether somebody is a renter, whether they're renting privately or whether they're renting from a social landlord, these sort of things. And so the data that I'm using is the annual population survey. So you've probably never heard of it. You might have heard of the labor force survey. So that's a data set that's collected every quarter by the Office for National Statistics to know how many people are unemployed, how many people are not in the labor force because they have a long-term condition. That's where we get all that data from the labor force survey. And they sort of do a booster sample where they ask people 4 interesting questions. So that came in with David Cameron. Like, people might not like him, but at least he did one good thing. Back in 2011, they started collecting these data because there was this idea that how do we measure the success of our economy or country? It has to go beyond GDP. Yeah, like just how much we are producing, that doesn't make anyone happy. We need to know how happy people are. So we are asking at a national level, on a scale of 0 to 10, how anxious were you yesterday? On a scale of 0 to 10, how happy were you yesterday? On a scale of 0 to 10, how satisfied would you say are you with your life nowadays? And on a scale of 0 to 10, how much would you say your life is worthwhile? So these are sort of different ways of measuring happiness. So this is all based on theory. So like the last one is like eudaimonic measure. For example, parents, that they will not be very happy if you have young children, especially, yeah. But they score highly on worthwhile. And, yeah. So like how satisfied are you with your life nowadays? That's like a more general assessment. Thinking about everything actually shouldn't be, can't really complain, yeah. But how happy were you yesterday? Maybe that's more informed of what happens day to day, and the same with how anxious were you yesterday. So we chose as our main health outcome measure how anxious were you yesterday, because we don't really expect immediate changes to physical health from improving housing conditions. That will probably be a long time before you see that, and that's why our stuff with the emergency hospital admissions is a bit messed up. Yeah, whereas the data that I'm analyzing is much more fun. So I'm going to show you the result. Basically, but it's a little bit complicated. What we would usually do is we would find a comparison group, and we would have, so that's what we've done basically. So we have all these areas that got selective licensing, and then we looked at their characteristics. So there's this percentage of the population are in this age range, this percentage of the population are from an ethnic minority group. So like lots of things like the IMD and so on. And we found very similar local layer super output areas in terms of these characteristics. So we found basically control groups that are very similar, as you were saying. And then the plan is to have before data for the areas that got selective licensing, after data, so we can see the change before, after. But obviously lots of other things are happening, like austerity and these sort of things. So we need to have a control group. So we have that matched control before, after data. So we compare the difference between the differences. So we have before, after, and maybe this goes up by 0.2 and this goes up by 0.1. And so the difference of the differences is 0.1. Yeah, so it goes up by more in the treated group than in the control group. So that's called a difference in differences strategy. The complication is that we don't have a same before after. Like some areas, they did selective licensing in 2015. Yeah, others started rolling it out in 2018. Others did it in 2012. So I have to do lots of little tiny analyses. So the first one I did was for 2015, because most of the selective licensing areas in our data set started in that year. So lots of stuff was going on there. And also I have a lot of people in there, because it's a little bit a lucky draw, because I'm using data that was collected for a completely different purpose by the Office for National Statistics. But because they want to get averages across the whole country, they sample people here and there and everywhere. Yeah, so I'm quite lucky that they also happen to sample people who live in the selective licensing areas. Yeah, so that I could actually calculate these means. So the red line is the anxiety variable in the areas that started selective licensing in 2015. And then there are different comparison groups. So the obvious one is what I just told you about, the dark blue one. That's the matched control group, where we try to match to each LSOA that's in the selective licensing area and other selective licensing, another area that's not selective licensing but has the same proportion of population in the different categories and so on. And you can see they look quite similar. I think we got the match quite right. We could also do all of the others, like all the other LSOAs that didn't get selective licensing. They're actually not that dissimilar. And then we were concerned, maybe there's still a difference, even though you match on observable characteristics. There might be something different about areas where people decide, okay, we need to roll out selective licensing here, and areas where they don't. So as another control, maybe use areas that get selective licensing at some point, yeah, but not yet. So that's the green line, and not yet. But they're actually not that similar. So all that work. What you can see is so things are sort of improving because being more anxious is not a good thing. But then look at this, 2015 is when they rolled out, yeah? So you compare to the year before, and this is a massive decrease. And it's like a small decrease in all and more an increase in the matched controls. And even if you keep comparing, it goes up here, yeah? So whereas here, at least they don't go back up. So you could think maybe there's something good going on there, yeah? And then we can do the same for areas that started in 2018, where I can't do that green comparison group because like I don't have anybody that hasn't, because these are my control groups for the earlier guys, basically. So you can see maybe not too much, but maybe something here, yeah, when everybody got more anxious. Do you remember 2020 COVID, 2021? And then these areas, at least people, they made some progress, yeah, they got down there. And then obviously it was harder to do something about, because the housing officers couldn't really inspect and so on, but you can see maybe there's something positive going on. And this is the third most populous group, like things that started in 2012. And here we see a huge impact, yeah, look, compared to before. There was this, and it sort of continues. Like obviously here this decreases, but if you compare, they actually seem to have a bigger decrease. So you calculate lots of little comparisons, and then you average over them. And that's what I get, basically. So in the first year, anxiety reduces, it reduces by more, because things sort of start embedding, yeah? You can really do something about it. And then maybe once it's over, nothing really, it goes back to, like there's still something there, but it peters out because they last for 5 years, as you know, yeah? And obviously I just say like 2012, maybe they started in July 2012, yeah? So this is why I also like that. Maybe it's like when they've fully finished, but I don't really know exactly when all this happens. So I think this is probably the most reliable. So you can see there's this decrease in that number where it was like 3.4, and then if you have 3.0 as the average, that's probably some progress. Actually, we defined it a little bit more straightforward. We said if you say 6, 7, 8, 9, or 10, we say you're anxious. And we want to see whether we can reduce the proportion of the population that says they are anxious. So I've redone this with this other outcome variable. And so you can see there's this drop in the proportion of people that say they're anxious, and it sort of gets better as it embeds itself. And it's highly statistically significant because the confidence interval in these years, at least, yeah, it's all on the negative side. So it couldn't just be a chance finding. If it goes far into the positive, maybe it's just a chance finding. So if we average in a clever way, like with weighted averages, that's the effect. And what does that mean? So in our data, 22% of respondents, so people who live in private rented housing, say that they have this anxiety level of 6 or more, which is quite shocking. Clearly, I'm on 0, something like that. So it's really hard for me to imagine that. So if you reduce it by this number, so you go from 22% to 18% reporting that. So that's basically a 17% drop in the proportion of the population that would report they're anxious, or think that's a good result. So the next step, which I still have to do, is the cost-benefit analysis. So for that, I'm going to use the life satisfaction measure. And we know that your life satisfaction increases when you have more income, and also when you have other things, like when you're thinking about getting married. Actually, getting married doesn't make you that happy. You go back to your normal level. But when you follow people longitudinally, and you know, because we have these longitudinal studies, yeah, we know they got married here, and then you look back at what they said each year. How satisfied are you with your life nowadays? Like the 2 years before they actually get married, it's really high, and then it all goes back to the steady state level. Same with divorce, it goes really down, and then the divorce, I was like, was it slightly different between men and women? So it's really bad in the year of the divorce and a few years, but then it goes back to normal. So we also know that more income makes you more satisfied with your life. So what I can do is, I know from the literature, this much increase in income increases being satisfied with your life from whatever, 5 to 5.5. And now I see how much does this increase my satisfaction with life. And then I know how much value it has. Yeah. So if what I found so far, have I got that here?